Yes, so welcome. Today we will start with the nephrology modules in surgery. So this is the first module of kidney. Uh, let's start. So let me tell you how will it be. First I will display you the questions here. Then you pause it. Pause the video and try to answer it. If you are able to answer it correctly, congratulations. Move on to the next question. And if you cannot answer or do it incorrectly, then see the explanation I am providing, then you will get the clear concept behind it. So let's start it. Start forward. So the first question is, which of the following statements is false regarding the surgical anatomy of the kidney? Options are renal artery is longer than the left renal artery. The line of Brodel is an important access route for renal surgeries. The renal arteries are end arteries without collateral circulation. The kidney has very poor lymphatic network. See, it has asked false. So now pause it and try to answer it. So, so let's move forward. So let us, if you have answered it, then good. Wait for me to reveal it. Now see, the surgical anatomy of the kidney. See, suppose this is the right kidney and this is the left kidney. Not suppose this is the right kidney and this is the left kidney. This is inferior vena cava and this is aorta. See, IVC is placed slightly towards the right side. So logically, the right renal vein will be smaller in size and the left renal vein will be larger in size. So right renal vein is smaller than left renal vein. Left renal vein is bigger than renal vein, and with the same logic the aorta is placed on the left hand side. So similarly we can say that the right renal artery, see, right renal artery is bigger than left renal artery. This is done. Now see, this is a peculiar feature. This is the right testis and this is the left testis. The left testicular vein, so this is the left testicular vein, this is at right angles to left renal vein. So as a result of this, this is more prone to varicocele, and these are the campaniform plexus. So as it is in the right angles to left renal vein, the left testis, testicular vein, this is more prone to varicocele. And see, this is not at right angle. This is normally connected to IVC, but this is at right angles to left renal vein, so this is more prone to varicocele. Left testis at right angle, so more prone to varicocele. Done. Now see, lymphatic networks. The lymphatic networks of kidney. And one more thing. See, in this place, the Nutcracker syndrome is observed. What is it? The left renal vein is compressed by aorta and superior mesenteric artery. So see, right renal vein goes up like this, and this is the left renal vein which is going up. And as aorta is in front, it sometimes may get compressed. The left renal vein may get compressed, which leads to nutcracker syndrome. Okay. And one more thing is, the left kidney is always chosen as a donor. Means if the donor can give two kidneys, then the left kidney is chosen. Why? Because the left renal vein is longer and it is easy to anastomose. See, the lymphatic network, it has lymphatic plexus which drains into lateral aortic node. Three lymphatic plexus are there from renal tubules, renal capsule, and perirenal fat. So, kidney is supplied by three lymphatic plexuses. And let's move on. Line of Brodel. It is a avascular plane of kidney between anterior and posterior segments. This is a avascular plane of kidney between anterior and posterior segments. This has no blood supply, avascular. As a result of this, this is important access route for both open and endoscopic surgery. It is helpful for the surgeons to do surgery. And another thing is end artery. Yes, no connecting branches, no anastomosis. End arteries means they can't do anastomosis, and they don't have any connecting branches. So which falls under end arteries? Which are end arteries? Splenic artery is an end artery, renal artery, artery to kidneys, artery to spleen, internal auditory artery in the internal auditory canal, and thalamoperforate artery supplying the thalamus, and basilar artery supplying the brainstem. This supplies the Basilar artery supplies the brainstem. These are all end arteries. So let us view the question. Now see, these are the answers. The right renal artery is longer than left renal artery. See, this is correct. This is the aorta, this is the left renal artery, and this is the right renal artery. The right, the right renal artery, this is the right side. This is obviously longer than this. And if it was vein, then right would have been shorter. Keep this in mind. Always remember, this is aorta, means if this is IVC, this is aorta. IVC is towards the right side. Okay, so this statement is correct. Right renal artery is longer. The line of Brodel is an important access route for renal surgeries. This is also true. They have asked us the first statement. The renal arteries are end arteries without collateral circulation. Yes, I told you. Renal arteries are end arteries. Renal artery, splenic artery, thalamoperforate artery, and artery to brainstem, basilar artery. The kidney has very poor lymphatic network. No, this is the wrong answer. They have three, means three lymphatic plexus supply it and they drain to lateral aortic nodes. So this should be the answer. This is the answer. Yes, this is the answer and this is the false statement. So see, hmm, answer D. Okay, let's move on. So I will move on like this. If you can answer it, then skip the explanation. If you know something, then skip the explanation. Okay, this was a good question. You had Means you needed to have the depth of knowledge. And if you can't, then see the explanation and like this we will move. So the first question has been dealt with. Let's move on. See, yes, lateral aortic nodes, the lymphatic plexus. It is good. Kidney has a good lymphatic network. Now move on to the second question. Which of the following statements is true concerning live donor and kidney transplant? This is another tricky question. You have to remember the means for dead donor and for live donor, the criteria. This falls under transplant question. So see, the options are the iliac fossa on the posterior abdominal wall is the usual site. The renal artery is anastomosed end to end to the external iliac artery. The renal vein is anastomosed end to side to the internal iliac vein. Right kidney is preferred over the left for transplantation. So pause it, answer, and then we will move forward. Okay, we have answered. So let's know. This is a tricky question, so we must know this. This is must. You must know the criteria for dead donor and live donor. In dead donor, we do end to side anastomosis and it's external or common iliac vein. And for live donor, we do end to end and it's internal iliac vein. And always remember it's renal vein. It's renal vein, not artery. It's renal vein that is anastomosed. And how we will remember this? The simple trick or the simple, not a trick, the way I used to memorize is suppose it is a dead donor. Dead donor means the person is dead. So what will you do? Means what will you do to the person after taking the kidneys? You will remove the person. Means you will either bury it or you will either cremate it or you will burn it. Means you will move the person to the side. The person has died unfortunately, so you will try to remove the person to the side. So by this way you can remember end to side. Means dead person, he has died, मर गया, जो आदमी मर गया उसको साइड में कर दो. And how you will remember this? वो मर गया, उसका सब कुछ बाहर डाल लिया, तो it's external or common. You remember it external. And the next trick is for the live donor, end to end. End to side for dead. So the only one remains is end to end. And how will you remember this? A live donor. Live donor means the person is alive. So they will have functional internal organs. The internal organs will be functional. So as a result of this, we do end to end with internal iliac artery, not external. External is for dead, into side. Okay, this is very tricky. Try to remember it this way, the way I explained, or you can have your own tricks. But the way I remember, I told you, dead donor person died, so we will side the person, so into side, and external side. Side means bahar, bayre, so external or common iliac artery. And live donor is end to end internal. The internal organs are alive. So yeah. And the last one, iliac fossa on posterior abdomen is chosen site for transplant. Yes, the posterior abdomen on iliac fossa. This is It's a fact based, you must remember it. So let us move to the questions. See, statements true concerning a live donor. Okay, let's see. The iliac fossa or posterior abdominal wall is the usual site. Yes, this is true, so this must be the answer. But let us see. Suppose this is a fact. Suppose you didn't know this. Then we will we will approach this question in a elimination method. Let's see. The renal artery is anastomosed end to end to the external iliac artery. See, renal artery, no, never artery. It's renal vein. And if this was renal vein, this is a live donor. Remember, he is live. So we will in live donor we do end to end, and what we choose? We choose here internal iliac because internal organs are alive. End to end, external iliac. No, live donor. This would be internal iliac. This is also wrong. The renal vein is anastomosed end to side to the internal iliac. Renal vein is anastomosed and no into side no. Into side will be in dead donor. मर गया तो हटा दो. Right kidney is preferred over the left kidney. Nah, bro. It's left kidney preferred because left left renal vein is longer. That's why it's preferred. Okay. So done. Now let's move on further. So the answer will be obviously A. And even if you didn't know this, by knowing all this, you could find out this. So answer will be A. Okay. Now let's move on. Intravenous pyelogram done for evaluation of a recurrent UTI, urinary tract infection in a child is shown below. Which of the following is false? This is very important. False regarding this condition. Okay, let's see this image. We can see this and again joining from this side. So see, these are the kidneys and they are joining. So see, the lower lobes are fused. So this is a typical case of horseshoe kidney. Okay, now let's look at the options and they have asked what is false. The options are: it is associated with increased risks of RCC, commonly associated with obstructive uropathy, lies just below the origin of inferior mesenteric artery, division at level of isthmus improves function. Okay, so pause and try to answer. And if you can't, then let's move on to the explanation. Let's go. So see, case of horseshoe kidney. First, let us understand the CECT and this one, pylorica. See, we will find a flower vase, or this is also known as handshake sign. See, the kidneys fuse and this look like a flower vase. See here also. See this this is the fusion. They're looking like a flower vase. And in CECT, you will see this. See this beautiful. Can you appreciate this? The complete lower lobe has been fused. Okay, so these are the images and some points are lower lobes are of the kidneys are fused. The lower lobes, the upper lobes are intact. Lower lobes. Ascent restricted by IMA. IMA means inferior mesenteric artery. This is important. Kidneys are formed and this is the inferior mesenteric artery. So this artery prevents the ascent of the kidneys. Okay, the artery is blocked. Inferior mesenteric artery prevents the ascent. Adrenal glands are normal, yes. Adrenal glands, we know these are situated above the kidney. So if adrenal glands are present, then they are normal. If they are present, L2 L3 fused portion lies. So the fused portion lies on L2 L3 L2 L3. Okay, done. Now see, complaints of most of the time they're asymptomatic, but the main thing is hydronephrosis in case of obstructions, lung infections, renal calculi, renal stones, renal pain, nephrolithiasis. Okay. Now, associated with increased risk of RCC. Yes, this is important. Renal cell carcinoma. Risk increases. Never cut fused portion or the isthmus. Leads to devascularize both kidney. Only exception is abdominal aortic aneurysm. See, this is a very important point. This is the kidney fused, and this portion is known as isthmus. Okay, so a surgeon must never cut this. If we cut this, then we might devascularize this. The blood supply might be hampered, and blood supply to both the kidneys may get hampered. So this is a very risk. So we do not devascularize. We do not cut the isthmus. That portion is never cut. Only exception when it is cut, only when the patient has abdominal aortic aneurysm. Only in this condition it is cut, but we never cut it normally. So let us move ahead in the see the options. So this I know flower-based sign in horseshoe kidney associated with increased risk of RCC done, commonly associated with obstructive uropathy done, uh, hydronephrosis obstruction is observed, lies just below the origin of IMA. Yes, this is also correct. The ascent is prevented by IMA and the division at level of isthmus improves function. No, bro, this is absolutely wrong. Wrong, but this is the correct answer as they have asked us what is false. No, division at level of isthmus improves function. No, nothing. And it can be detrimental, danger, as it devascularizes both kidney. Danger. Okay. Uh, let's move ahead. Fourth question. Yes, so this one's answer is D. A child was brought to clinic for evaluation of recurrent UTI. Ultrasound revealed a dilated renal pelvis. Okay, the if this is the kidney, the pelvis part, this portion is dilated. Intravenous urogram done is shown below. What is the most likely diagnosis? Now see this what you are seeing. This is a classical droop lily sign. Droop lily sign. And this is observed when in a congenital anomaly when they have two ureters. Two ureters. This is an easy question. When they have two ureters, this is the A. Yes, the upper lobe and the lower lobe are not properly fused, so two ureters come out, and this sign is produced. Drooping lily sign. So, what is the most likely diagnosis? These are the options: duplex kidney, retrocaval ureter, childhood PCKD, and horseshoe kidney. Pause it and we will answer it, and after that, we will learn about this. Yes, so the easy answer is duplex kidney, not retrocaval, not childhood, horseshoe kidney. I explained duplex kidney. They give out two ureters. Okay, now let's learn about drooping lily sign. This sign is known as drooping lily sign. Okay, let's learn. Two ureters, congenital anomaly. Two ureters are found and these are congenital anomaly. See, this two ureters. This is ectopic and this is normal. Normal comes from the lower pole of the kidney. If this is the kidney, oh, what happened to my drawing? If this is the kidney, normal comes from lower and upper pole is ectopic. And say upper pole, this is ectopic. And they open two places. One is medial and one is posterior but lateral. One is medial, another one is posterior and lateral. So incomplete fusion of upper and lower pole of kidney. Yes, the poles of kidneys are not fused, upper and lower lobe. That's why two ureters are produced. Common features. This is very important. RTI incontinence. Yes. RTI recurrent. Sorry, why RTI? Recurrent UTIs. UTIs. Yes. Recurrent UTIs. Not able to control it. Females always wet. This is very important. When a mother brings her daughter, they say that she is always wet. Why? Because she is not able to control her urine outflow. The normal lower pole, this is controllable, but the ureter coming from upper pole, this is not controllable. So the urine always drips. Urine drips, so the child is always wet. Okay. Investigation of choice: IVU, intravenous urogram, RX, reimplantation of ectopic ureter. This is the management. The ectopic ureter from the upper pole is reimplanted. Okay. So this is the answer, duplex kidney. Now let us look at some of the other options. Retrocaval ureter. What is retrocaval ureter? Retrocaval ureter happens when this the renal artery. So yes, this one. This is retrocaval ureter. Right ureter presses behind IVC, internal vena cava, reverse J sign, fish hook sign. This is the right ureter. The right ureter is pressed by the IVC. As a result, it gets a swollen. This is the appearance, and in IVU you get uh, this appearance. Reverse hook sign, reverse J sign or fish hook sign. The retractable ureter, the ureter goes behind. That's why it gets pressed. Okay, so the answer here is uh, duplex kidney. Retractable ureter I explained. Childhood PC kidney means polycystic kidney disease. No, in that case there will be multiple cyst in kidney like that. And horseshoe kidney I already explained like this flower vase sign in the above question. So by this also, this is an easy question. No much, not much explanation needed. Fifth question: a known hypertensive presented with intermittent left-sided flank pain. His brother passed away 2 years ago due to ruptured very aneurysm. Okay, this runs in the family. CT abdomen done is shown below. Which of the following is false regarding this condition? The options are decompression of cyst improves renal function caused by mutation in chromosome 16 associated with mitral valve prolapse leads to chronic renal failure. So they have asked which of the following is false. Okay, pause and answer and we will move forward. Okay, let's follow. Now see, before we move ahead, what clues are we getting from the question? Okay, they have said his brother passed away 2 years ago due to a ruptured very aneurysm. So this can be, we can call it autosomal dominant trait, not recessive. And see, we can clearly see these are the kidneys and there are multiple cysts. So this is a case of polycystic kidney disease, PCKD. So there are two types. One is childhood and another one is adult. So this is definitely adult. As this one is dominant and in childhood and this presents in 20 to 30 years of life, means in second to third decade of life. Okay, adult PCKD, childhood PCKD, autosomal dominant, this is autosomal recessive. So this wouldn't have been passed on to next. This has been passed on. So dominant, compatible with life. They can live longer. So see, they are presented in a later phase of life, but this is not compatible due to uh, hepatic fibrosis. Hepatic fibrosis happens and they died immediately at birth. Hence they die recently. And see, the chromosome here is 16 and 4, and here is 6. This is important. Remember it. See, you can remember this. This is adult. The adult is bigger, so this is a bigger number, chromosome 16. And this is child small. So the smallest, we remove the 1, we get only the 6. Okay. The manifest 20th day, manifest at birth. See, this is how we will find out. Hypertension among young adults is a, you must strike adult PCKD. Hypertension in a child means a 20 child means young adults 20 to 30 years of age. This is most common PCKD, polycystic kidney disease. The other differential diagnosis for this can be renal artery stenosis, pheochromocytoma. All this can be there. Renal artery stenosis, pheocyte, and hyperthyroidism. But this is important. Okay, prenatal USG. Now see, if prenatal USG with that more than 3 cysts unilateral kidneys, then it suggests PCKDs, or if you get more than 2 cysts bilateral in both the kidneys, then it suggests PCKD. Management, long-term dialysis, transplant, and medicine is vasopressin receptor antagonist. Important. Other manifestations are of this multiple cyst in liver. This is the most common manifestation. There are multiple cysts in kidneys, multiple cysts in the liver, mitral valve prolapse, bare aneurysm, colonic diverticulum. These are all important. These are other manifestations. Decompression doesn't improve renal function. You might think that if you decompress, then the renal function may be improved, but no, it doesn't improve. The only treatments are long-term dialysis or kidney transplant and the medicine vasopressin receptor agonist. Let's look at the options. Decompression of cyst improves renal function? No. What is it? Here the following is false. False. Decompression renal function. It doesn't improve. This is wrong. But false facts, so this is the correct option. Let's cause by mutation chromosome 16, yes. Chromosome 16 and which one? Chromosome 4. And also 2. And for childhood that is 6. Only 6. If it was only 6 child. As usual with mutual bulk plus 2 leads to chronic renal failure. 2. Let me have some water. Okay. Sixth question. Move on. The following image shows retrograde ureteropylogram RGU. Means the dye is injected from penis and upwards. Means retrograde, opposite to the flow of direction of urine. Patient with loin pain. What is most probable clinical diagnosis? See, this is the diagram. This is the kidneys. Options are hydronephrosis, duplex kidney, renal carcinoma, renal stone. Pause and we will find the answer. Okay, you have paused. So see, before I explain, by the previous knowledge only we can answer this question. See, we can clearly see this is the ureter. This has been marked here. This gets constricted. See, then it gets narrowed. Okay, this is one feature. And here you can see the renal calyxes are clubbed. See, they are clubbed like this. You can see clubbed. They are clubbed. Normally, calyxes are like this, but in this case, they have become like this. This is a typical case of hydronephrosis. Also, if you had no idea about this, how would you answer this? See, duplex kidney? No. Duplex kidney will show drooping lily sign. Drooping lily sign. That is from two ureters ka that one. Renal carcinoma, no. Not a renal carcinoma, and renal stone, no. Renal stone I showed you, they would be like this. Okay. Renal stones, sorry, beg your pardon. Renal stones are different. Okay. Renal stones are different. We will learn about them. So this is the answer. Now let's learn a little bit more about it. Left ureteropelvic stricture. See, this is the stricture 1 plus cleft calyces. This is hydronephrosis. This is normal cleft calyces. Answer is a sorry hydronephrosis. See, this is a stricture and this is cleft calyx. This is a better picture. See, strictured, constricted. This is this. See this. You can see this is normal. See, this is normal, but this is so constricted. And next question. An ultrasound can done at 32 weeks for a woman with oligohydramnios revealed fetal hydronephrosis. What is the most likely cause for the condition? Ureteropelvic junction obstruction, vesico-ureteral reflex, ureterocele, posterior urethral valve. Pause and answer. This is an easy question. What is the most likely cause for this? The most common cause for hydronephrosis, fetal hydronephrosis is this. UPJ, ureteropelvic junction obstruction. UPJ obstruction. This is the most common, and vesico-ureteral reflex. This is the second most common, but most common. So A will be the answer. Okay. UPJ obstruction, most common cause of hydronephrosis. Intrinsic causes are stenotic segment. Extrinsic causes are due to accessory renal arteries. Okay. Most common. The management is Anderson Hines pyeloplasty. Management for hydronephrosis is pyeloplasty. And see, let's learn about vesico-ureteral reflex. This is the second most common cause for hydronephrosis. And this is the valve. What is this? Vesico-ureteral valve that prevents backflow of urine into the ureter from bladder is defective. Means this is a ureter, this is the bladder. There is a valve that prevents urine backflow. This valve here is defective, so urine goes up. This leads to hydronephrosis, but this is the second most common cause. Ureterosis. Ureterosil. What is ureterosil? This is cystic dilation of terminal ureter. See this. The ureters at the end get abnormally dilated. See this. Often known as cobra head appearance. See? Head like cobra you can see. You see? Renal stones are most common cause of acquired unilateral hydronephrosis. Okay. So the answer is, let's move on. The answer is UPG obstruction. Most common cause. Okay. Eighth, eighth question. A mother brings a old infant to OPD with complaints of him crying while urinating. On palpation, a left-sided flank mass is felt. A USG of KUB means kidney ureter bladder revealed dilation of pelvic calcium system with a normal looking distal urinary tract. Means the distal portion is normal. This is not inflamed or constricted. What is the investigation of choice to confirm his diagnosis? Cause it, he will answer. Okay? Cause done. Still see the question. I am crying while urinating. Cry while urinating means painful micturition. On palpation, left-sided flank mass is spread. Okay. Is a cavity revealed dilation of pelvic fascial system. Means this portion is there. This is UPJ obstruction. Not obstruction, dilation. With a normal looking distal urinary tract. This has been dilated. So what is the investigation of choice to confirm the diet? Intravenous allogram. This is radioisotopy. Creating cystourethrogram or RGU. Okay. Let's see. Kidney. See, to anything for kidney, the investigation of choice, mainly we have two, either for the structure or for the function. Anything for kidney, either it is structural or functional. For structural, we do technetium 99 DMSA, and for functioning, we do MAG3. This is the best. Tech 99 MAG3, and for structure or sky, we do Tech 99 DMSA. To test the kidney structure, Tech 99 DMSA. For the functioning of kidney, we do MAC 99 Tech MAC 3 gives total GFR. If it is more, then it is functional kidney. More than if the total what do we get from 99 Tech MAC 3? That we get total GFR. Now if it is more than 10, then the kidney is still functional. But if it is less than 10, then it is not functional. Then we prefer nephrectomy. Hence removal of the kidney. So what will the answer here? Answer will be 99 Tech in MAC 3. 99 PC MAC 3. No, these are not done. These are not done. Very important. And MAG 3 is for functional, and DMSA is for structure. Okay. And micturating cystourethrogram, this is for vesicoureter deflex. This is done in VUR. We read it above. Micturating cystourethrogram. Micturating. Child was brought to you with recurrent episodes of colicky, abdominal pain, usually revealed left-sided hydronephrosis. On the third follow-up day, a decrease in abdominal pain was noted after he passed a large amount of urine. Repeat USG showed a significant decrease in the size of the left kidney. What is most likely diagnosis? Was an answer? Already. See, this is a very typical sign. This is clearly known. This is a fact-based, and this is Dieter's crisis. What is Dieter's crisis? The scenario is pain relief after passing large amounts of urine in hydronephrosis. Okay, and yes, forgot to mark it. This was answer B. Yes, and this one, Dieter's crisis. Answer is A. Remember the scenario. Pain relief after passing large amounts of urine in a case of hydronephrosis. intermittent UPG obstruction, and the management is pyeloplastic. No, this is not multicystic dysplastic kidney. No, not ureterocele, not childhood polycystic kidney disease. They are recurrent episode of decrease abdominal pain. This is diabetes crisis. The pain will decrease. Question 10. Which of the following are risk factor for calcium stone formation? Hypercalciuria, hypercitraturia, hyperoxaluria, hyperuricosuriya, hypermagnesiuria. Pause and answer. Okay, see. Let's move, then we will answer this. See, renal stones. The risk factors are calcium oxalate, uric acid. Yes, calcium means calcium in body. Remember this. Calcium inside body, not in a diet. This is a very means you can say tricky. Not if they said calcium was in food, then it wouldn't have been a risk factor. But they have said here hypercalciuria. This means calcium present in urine. So this is obviously a risk factor. Okay, and protecting or inhibitory factor citrate and magnesium. This is for all renal stones. This is very important. Citrate acts as a inhibiting factor, means it will not promote, it will demote. And when are stones found? When Cp is more than Fp. Cp means concentration product is more than formation product. Formation product means maximum concentration of solute along taking in consideration the stone inhibiting factors. And this is concentration product is amount of solute in the solution. When Cp is exceeded means more means the concentration of solute is much more, then only stones will form. Let's get back to the questions. So see, hypercalciuria, yes, one is done. Hypercitraturia, yes, this is very tricky. No, citrate is not involved, so two is not present. Citrate is not present, so we will remove the options having two. A has two cut and D has two cut. So these two options only remain. B or C. Yes, calcium is done. Now we must check only one, 3 or 4 to confirm our answer. Hyperoxaluria, yes, if oxalate is more, then the risk factor for calcium stone increases. And also uricosuriya. So the answer will be B1, 3 and 4. Elimination method. Next question, we will do it a little bit faster. Which among the following is the IOC in patients suspected with ureteric stone? So, in ureter, answer. First you answer. Okay, done. Now pause. Done. Okay, let's see. NCCT is the investigation of non-contrast CT scan is investigation of choice for ureteric stones, any stones in the ureter, renal stones, any stone in the kidney except Indinavir stones. Why Indinavir stones? It is drug induced. Indinavir stones are drug induced and it is also radiolucent. Head injury, salivary gland stone. NCCT is always investigation choice for ureteric stones, renal stones, except this head injury, any kind of salivary gland stone. So this ureteric stones, so always non-contrast CT abdomen and pelvis, NCCT. Not plain X-ray, not IVU, for stones. Intravenous ureogram for what? For dilatations or something like that. But NCCT is here. For stones, it is NCCT. Amen. Let's move on to the next question. Yeah, a man presents with a casualty with fever and hematuria for 3 days. He also gives a history of recurrent left-sided pain radiating to the groin, loin to groin pain. X-ray QV is shown below, which are the following is false regarding stones. See, the false. Okay. Now see, these are the options. You can see the stones. The option are composed of CA, ammonium, Mg phosphate found in acidic urine, increased risk with infections by urease producing organisms, and rectangular or coffin lid appearance on microscope. Okay, pause and answer. Okay, now see, I will this will take a bit time because I will explain you everything about renal stones. Okay, I will explain everything about renal stones, uh, so you can answer all of them. And after I explain, you will be able to answer this, and then I will means say another way to answer this question, easier way, more of a exam oriented way. First, let us understand this about renal stones. Okay, let's see renal stones. There are mainly five kinds: one, two, three, four, and fifth. Five kinds. Okay. First is the calcium oxalate stones. These are the most common renal calcium oxalate stones. Okay, they are monohydrate. It is dumbbell shaped and it is very hard. It can't be broken down by ESWL. It is a method to break down kidney stones. It can't be monohydrate calcium oxalate stones can't be broken. Dumbbell very hard. Remember this. This is a trick. Very it can work. So this is a shape monohydrate and it is dumbbell shaped, so it is very hard. Dihydrate. This is envelope shape. This can be broken down by ESWL. Okay. This found in acidic urine. Okay, calcium oxalate stones found in acidic urine. These are radio opaque. We can see them in X. Speculated margins, mulberry stones. If stones are shaped like this, then these are mulberry stones. And what do we advise? Dietary advice: fat less, but see calcium more. Calcium, if we take more, then the oxalate present in the diet they will mix with it, and the stones will not be formed. So calcium is means it is advised. Fat intake will be less, and the medicines can be given cholestyramine and pyrid, pyridoxine. Pyridoxine in large doses is recommended. See, this is a very important table. Remember this, all questions will come from this. Oxalate stone done. Second is triphosphate. Triphosphate or struvite or stagonotones. Why it is triple phosphate? Because it has calcium, ammonium, and magnesium phosphate. The only difference is this is alkaline. Remember this. This is acidic. This is the only stone which is alkaline. How it happens? It happens because of urea breaking organisms. The organisms that break down urea in your body, they are termed as UDAs, urea breaking, which are the Protease and Klebsiella. Means if these organisms are more, then more of these triple phosphate stagon and strobite stones form will be more. And their shape is coffin shaped. Remember the shape, the coffin lid shape, like this. This was the dumbbell shaped, and this was the envelope shape, and this is coffin shaped. Grows in size, takes up shape of calyx. This is very important. They grow in size and they take up the shape of calyx in kidney, and they are radiopaque. This was also radiopaque, and medicinal advices acetohydroxamic acid. See how we will remember this. We will give acid. We will try to acidify it because the it is formed in alkaline urine. So if we acidify, then the chances of this alkaline stones will decrease. So acid hydroxamic acid is suggested. Now the third type of stones are cystine stones. They are found in cystinuria. Stones made up of cystine. They are very hard. They are harder than the dumbbells also. They are hexagonal crystal lattice. This is the shape. Hexagonal means six sided. This is this. They are radio opaque. All these three are radio opaque, and they are if the stones are recurrent, then the medicine is given D-penicillamine. Okay, D-penicillamine for cystine stones, for staghorn stones, acetohydroxamic acid, and for calcium oxalate, pyridoxine or cholecystidamine. Pyridoxine large doses. Okay, three types done. And the fourth is uric acid stones. They are radiolucent. They can't be seen in X-ray. This is very important. Radiolucent. Glass shaped means glass shards. Shard like this. Like yes, like this shard like shape they will have. See shard like shape. Medicine is given allopurinol. If it is recurrent, allopurinol is given. This is associated with gout, tumor lysis syndrome. Uric acid is more in uric acid, and these are some rare stones, but these are important. Questions come from this. Radiolucent. Xanthine. Xanthine is brick red in color. See, I have written it with red color so you can remember brick red. Indinavir stone and trimeterine. They are drug induced. Drug-induced stones. These are indinavir and trimeterine are drug-induced stones. And ammonium urate stones, this is associated with laxative abuse. Means if a patient takes too much of laxatives, then ammonium urate stones can be found. Okay, so done. Now let's get back to the question. This was a little big explanation, but if you can remember this chart, then all the upcoming questions, all the upcoming stone related questions will be done. Okay, just remember this. These three are radio opaque, these two is radiolucent. All among them are acidic except this one, number two. This one is basic. For basic, we give acidic management, and this management is pyridoxine, and this management is penicillin, and this is allopurinol, uric acid. Okay, remember the shapes. Let's go to the question. So this was the question. You can see these are the stones, and see this is not dumbbell shaped. This is not envelope shaped. This is not a glass shard like shape. They have a coffin lid appearance, which is not understandable here. But another point for, yes, triphosphate stones were, they see they grow in size and take up shape of calyx. So here you can see they are taking the shape of calyx. So I can clearly understand that this is a staghorn or struvite or triple phosphate. Okay, so now they have asked which is false. So false, composed of calcium, no, this is correct. Triple, yes, triple stone, triple phosphate stone found in acidic urine. No, this is wrong. So this is the correct answer because this is found in alkaline urine or basic urine. Okay. Increased risks with infections by urea's protection organism. Yes, we done Proteus and Klebsiella. They break down urea into uric acid. So the means uh sorry. Basic. So the breakdown urea. So their concentration increases. Alkaline concentration increases, so they are a risk factor. Rectangular coughing lid appearance on microscope. Under microscope, you will have this appearance. So this is the answer, answer B. And now let's move on to the tricky part. How will trickily solve this? Okay, you can see this by elimination method composed of calcium, ammonium, and magnesium. So if this option is, so by this we have staghorn stones. Okay, and they have, if you are not able to understand this, then how will you solve this in an easy way? First, okay, we have to find the first statement. So if this is true, formed in acidic urine, no, these stones are not formed in acidic urine, so this has to be false. And if this is true, then this has to be false. So both of these are contradictory. Now how we will understand which one is correct and which one is false? By understanding the next option. See option C, increased risks with infection by ureas. Okay, so this alkaline, this also alkaline, this also alkaline favors. And see rectangular coffin lid appearance, this is the easiest option. This and this match, this doesn't match, so this has to be false. And this three match, this doesn't match, so by this you can find this out. This was a trick. It's the easier way. In exam you have to use this, or the knowledgeable way. This chart is very important. Next, all question will be done in one line. Acetohydroxymic acid will be prescribed for patients with which of the following arrangement? Cause and answer. So see, this is acid. This is preferred in patients with basic or which they have alkaline urine. So which is alkaline? This is triple phosphate. Triple phosphate is also staghorn or stuvite. Staghorn or stuvite. So option is answer D. Answer D. Okay, done. Let's move on to the next question. A patient is referred for evaluation, several right-sided abdominal pain, abdominal X-ray appears normal. X-ray is normal and USG revealed the presence of 6 mm renal stone. Which of the following stones is most likely to be seen? See, X-ray normal means X-ray में कुछ नहीं मिला. Nothing can be seen in X-ray, but USG debate. So X-ray normal means it has to be radiolucent, not radio opaque. So which was radiolucent? Number 4 type of stones and number 5 type of stones, which was number 5 uric acid and number 5 was special stones or rare stones. So let us see uric acid is there or not. Uric acid is there. So this is true and this all are radio opaque. So answer 3 done. Radio opaque, radiolucent. These are all radio opaque. Stagons, cuvite, cystine. See radiolucent this uric acid, ammonium urate, xanthine, indinavate. Special stones. Xanthine brick red. Indinavate drug induced. Let's move on to the next question. These are easy. If you remember that chart easy. See, the urine microscopy of a young man admitted with evolution of renal stones following finding. Which which type of stone is this? Pause and answer. Very easy. Which type of stone is this? This is hexagonal. 6. Crystal lattice. In which type you find? Which type you find this? Tell me. Cystine. Cystine urea. Cystine. So answer C. There were let me again do a quick recap. 4 kinds of stone. First was calcium oxalate. Calcium oxalate were either dumbbell, okay, or envelope. Another one was spiculate mulberry stone. These were calcium oxalate. Second type of stone was triple phosphate, okay, stag or struvite. What was it? There was coffin lid-like appearance. Okay. Third, third comes cystine. Cystine they have hexagon. This is hexagonal. Fourth was uric acid. Uric acid has glass glass shard. Yes, they'll have like this glass shard. And fifth was special stones, xanthine and all those. Remember this. This is this is acid. This is basic. This is acid. This is acid. This is radio opaque, radio opaque, radio opaque. This is radiolucent, radiolucent. Sorry, acid, radiolucent. Okay, done. Which of the following statements is false regarding renal stones? Another one-liner pause and answer. Done. Move on. A low calcium diet can prevent the risks of this is false. Haha. Low calcium, not calciuria, not in blood or calcium. Low calcium diet. A calcium rich diet is means indicated. They will means react with the oxalate and reduce the formation of calcium oxalate stone. So this is the wrong. First option is wrong and this is false. Let's read the other options. Potassium citrate reduces the risk of uric acid stone. Yes, citrate is an inhibiting factor. D-penicillamine. D-penicillamine where they are used in recurrent cystine stone formations and pyridoxine calcium oxalate stone formation. Okay, correct. So this is the false statement, but this is the correct answer. Answer is. A low CO2 diet has not shown any effect compared to normal calcium diet. However, diet rich in calcium and bind with dietary oxalate and reduce risk of calcium oxalate. The- Another one-liner. An HIV patient casualty with intermittent right-sided flank pain is suspected to have renal stone. Which of the following drugs is most likely responsible for this condition? First answer. The answer is indinavir. This is drug induced. Indinavir and trimethoprim they are drug induced. चलो drug induced renal stones. Lamivudine, ephinovirus they are given in means AIDS treatment. They are not responsible. Responsible is this drug induced renal stones. 18. Which of the following are renal stones are produced by laxative abuse ammonium urate? Done this. Especially in the special stones. So that's why I'm telling. If you just able to understand this and this, then all your questions will be done. Say ammonium urate associated with laxative abuse. Done. They're all one-liners. A woman with severe right-sided colicky loin pain is suspected to have renal calculi. What is maximum size of calculi up to which the patient can be managed exclusively? Pause and answer. Done. So the up to which size it can be managed on medicines or conservatively managed without the need of surgery. It is up to up to or less than 5 millimeter. And how we write 5 millimeter? It is 0.5 centimeter. So this is the answer. This is a fact, but we will how we will manage stones. I will explain you in a flowchart and we will again be able to do all the questions. Okay. So the answer is A. Okay. This one. 0.5 centimeter. Okay. Now let us study a bit how no, so this is how we will manage renal stones. Management of renal stones. Because there are two types of one is renal, one is ureteric, another is in ureter, another is bladder stone. Okay. So renal stone management. Up to 5 mm, 0.5 conservative management. If it is more than 5 mm, then we give a medicine, tamsulosin. This is done till it is 6 millimeters. And if this means tamsulosin fails, then we move on to give ESWL. This is shockwave therapy, and this is applicable up to the size 1.5 centimeter, means 3 times. 0.5 centimeter conservation and up to 3 times we can do ESWL. And the other means in some patients ESWL is contraindicated. We do RIRS or URS, ureteric removal of stones. This is mainly done in ureteric stones. Okay. If ESW also fails and the stone has more than 2 centimeter size, we do PCNL, percutaneous. And if PCNL also fails, we do open or laparoscopic surgery. This is pyelolithotomy or nephrolithotomy. Okay, just remember this table. And for ureteric, we have some stones in ureter. It is 0. Means URS, and if it is impacts a lot, size is a lot more, then we go with nephrolithotomy. Okay, wait. Where was the management? Wait, let me yes. This is the management for ureteric stones. If it is 0.5 centimeter, means 5 millimeter less, we do a conservative management. More than that, then if it has no impact, and if it has impact, if it has no impact, then URS, uretary removal of stones. If this fails, we do ureterolithotomy. And if it is more in size and it impacts, then also we do ureterolithotomy. Okay, now let's do the questions. Okay. This was done 0.5 and these all these are one liners. In patients which are the following renal stones will extracorporeal shockwave lithotripsy not be considered? ESWL. ESWL is contraindicated. Okay. Pause and do. Answer do. We can't do ESWL if it is a very hard stone. Which are hard stones are made of cysteine as they have hexagonal crystal lattice structure, and another is dumbbell. Dumbbell was here. What was dumbbell? This was monohydrate. Monohydrate C oxalate. No dumbbell, no dumbbell, no dumbbell, only cysteine. So this is the correct answer. Okay. Answer is D. Let us now learn some of the cysteine hardest. Cysteine is harder than dumbbell also. I told you before. ESWL contraindicated in obese patient, pregnant patient, in children, and if it is hard stones, cysteine or monohydrate stones, in bleeding disorders, if stones are more than 1.5 centimeter, obstruction of urinary tract, and arterial aneurysm near stones. So these are all contraindications. But remember this point: saccular or berry aneurysm is not a contraindication for ESW. This is a very important point. Saccular or berry aneurysm, it is not contraindication for ESW. Arterial aneurysm is, but not saccular or berry. Okay. 21st question. ESWL is contraindicated in all of the following patients except uh, a young woman with untreated bleeding diathesis, yes, contraindicated. Pregnant woman, a man with ureteric stricture, ureter obstruction. A middle-aged man with saccular, no, this is not contraindicated. This is the answer. In arterial aneurysm, it is contraindicated. And a man with saccular aneurysm, not contraindicated. See this one. Answer is D. Next question. 22-year-old elderly woman brought to hospital with history of severe loin pain for past 7 hours. Ultrasound kidney reveals kidney 2.5, very big stone. What is treatment of choice for this patient? In kidney choice, was an answer. Was done. ESWL up to 1.5 centimeter. It is more than so. No. Ureteroscopic. Mainly it is preferred in ureters. Open surgery. No. PCNL, percutaneous nephrolithotomy, PCNL. If this fails, we go on to this. But first, we will try PCNL, more than 2 centimeters. Answer is B. Next question. A man came to casualty with right-sided colicky pain, radiating to inner thigh, insensitivity, abdomen revealed, non-impacted 1 cm calculi in right ureter. How will you manage this patient? Was an answer. Done? Important. As I explained, see, this is 1 centimeter calculi in right ureter, and this is non-impacted. Non-impacted ureter, so we will go for ureteroscopic removal. As it is in ureter, ESW is not done, PCNL is not done, analgesics are done up to 0.5 mm, 0.5 centimeter and 5 mm. Units are important, remember this. And the last, see this, no impact, then ULS. If fails, then lithotomy. And if it has impact, then lithotomy. Okay. As in ureter, not impacted. Ureter shows removal. Answer is C. And this is the last question. Pause and answer. Done. A man brought to casualty with severe left-sided colicky flank pain. On examination, he has febrile BP 90 to 60 mm, free rap, feeble rapid pulse. Pulse is also revealed. Means he has a sepsis. WBC is so less. 2.5 centimeter in ureter, acha. Ureter more than 2 centimeter, what is preferred management? Nephrology. ESWL not, ESWL is done up to 1.5 centimeter. Percutaneous ureteroscopic removal is done only when it is no impact, but here we can see an impact. Means pressure is also low, WBC less septicemia, so we will prefer nephrostomy. ESWL 1.5, no nephrostomy. Answer. Extremely unwell patient. So nephrostomy done. Okay. Thank you for staying. Do comment, and this was my first video recording like this. Obviously, I will try to improve if there was anything. Means give suggestions if you want improvement on anything, because this is my first time recording like this, and I started at some points. I was fumbling. I will try to improve all of them. And thanks if you have stayed like this, and I will try to continue all the modules like this. Okay, thanks. Goodbye. Have a nice day.